Hello, ladies and gentlemen, and thank you for joining our e-seminar, Fall Risk Assessment for Older Adults, an Evidence-Based Approach. My name is Teresa Boone, and I am the Director of Global Education at Natus Medical, and I'm honored to be your host today. Your line has been muted during today's presentation, and if you have questions for our guest speaker, please type them into the chat box or the Q&A box located on the right-hand side of the screen. I'll moderate those questions at the end of today's presentation with our guest speaker. Today's e-seminar will last approximately 45 minutes, and we'll have 15 minutes for questions and answers at the end. This e-seminar will focus on clinical examination tools that have been determined to be valid and reliable for predicting fall risk in older adults. The qualities of these standardized outcome measures will be discussed as they relate to time, equipment needs, appropriate populations, and type of body system and functional problems identified. Fall risk reduction strategies will be presented and discussed. I'm thrilled to introduce our speaker today. Dr. Peggy Roller is a professor and graduate coordinator in the Department of Physical Therapy at California State University, Northridge, where she teaches courses in applied neurology, functional testing, and balance and vestibular rehabilitation. She's a practicing physical therapist with over 20 years of experience, a clinical instructor for Neurocom International, and a published author and section editor of the textbook Neurological Rehabilitation. Her research interests are in the area of balance testing and training and reducing fall risk in older adults. Dr. Roller, thank you for your willingness to share your clinical expertise today. Without further delay, I'd like to turn the presentation over to Dr. Roller.
Thank you, Teresa, and welcome everyone. It is my pleasure to present a brief seminar for you on fall risk assessment for older adults. Teresa gave you a little bit of an overview of what we're going to be doing today. We are going to talk a little bit about examination tools that can be used to predict fall risk. We're going to focus on older adults, specifically community-dwelling older adults. There are lots of tools available, so we'll present them as many as we can that are appropriate to measure fall risk. We'll spend a little time discussing the components and qualities of these tools as they relate to time, equipment needs, and also how they relate to the minimum requirements that some of these patients need to be able to perform these tests, which is a little bit difficult to determine sometimes. Then at the end, we'll spend a little bit of time relating the results of tests to fall risk reduction strategies and give you some resources for fall prevention. So what we'd like you to be able to do by the end of today's brief seminar is to use the International Classification of Functioning Disability and Health, the ICF model, to basically classify fall risk measures in different domains, depending on body system, whether it's an activity measure or whether it is a measure of participation in life events. Also take a look at the psychometric properties of some of these tools to make sure that we're using tools that are valid and reliable, and also using tools that are measuring what we intend them to measure. The time, equipment, and minimum level of participation required will be discussed briefly for each test that we go over, and then the value of the results for planning interventions. So you are all here today. Let me back up one slide here. We're all here today because, like me, it's very confusing sometimes to choose fall risk measures for the populations that you're testing, whether you're in the clinic or whether you're a researcher and trying to determine how to measure fall risk in older adults. It's a very complex calculation. Knowing what causes people to fall is sometimes difficult to figure out. There's also not one single tool that's been designed to measure fall risk in all patient populations and all client populations. So with the number of tools that are out there, it's sometimes difficult to choose the appropriate tool for the people that you are testing in your clinical environment. There's also no gold standard measurement tool that addresses all aspects of fall risk. Bigger, better, and more comprehensive tools are being developed and have been developed in the last 5-6 years. to try to address all aspects of fall risk. But then these tools become a little bit longer and cumbersome to use, so we'll take a look at that. And they also, we want to consider that there's multiple outcome measures used to determine these, and the choices just can be fairly confusing for people. So hopefully we'll clear some of that up for you today, and you'll be able to make better choices in your own environments. A few operational definitions. We are going to be looking at tools that have been validated. All the tools we'll look at have been validated for use with community-dwelling older adults, and that's defined as adults age 65 and older who may or may not have experienced a previous fall. So that's the definition of our population. A fall is defined in the literature as a sudden episode of coming to rest on a lower surface. And what we're interested in today is measuring fall risk. Fall risk is the likelihood that a person will experience a fall in the future. So that's our objective today. It's an important thing to measure because community-dwelling older adults, statistically, 1 in 3 people over age 65 have taken a fall. Once a person falls, even that single fall doubles or triples the risk of that person having a future fall. So just simply getting a fall history helps the prediction of future falls. Also, it's a costly problem in our society here in the U.S. In 2010, just a few years ago, there were an estimate of $30 billion spent on medical costs related to falls and fall sequelae, such as broken bones and head injuries, and it's predicted to increase by the year 2020 and continue to rise. It is the most common reason for hospital admissions in older adults, and it is the leading cause of death due to injury, not disease, for that population. Intrinsic risk factors related to fall risk in community-dwelling older adults has been well studied. So we know already that people who have weak leg strength or are weak in the lower extremities, that increases their risk for falls. Any impairment in sensory systems or the inability to use these systems for balance, this includes vision, vestibular, and somatosensory information, can increase fall risk. Impaired cognition and especially attentional demands, impaired balance, which is a broad construct, and then problems with walking, unstable gait, unusual deviations and variations in gait, and especially slow gait velocity contributes to fall risk. And then on a participation side, the fear of falling or a lack of confidence in balance also contributes to fall risk. So what we're going to do right now is take a brief look at the ICF model of health and disability. This is the International Classification of Functioning, Disability, and Health. Many people are quite familiar with this tool. What we're going to look at is this middle section right here that I'm kind of drawing a circle around for you. We are going to be interested in choosing and using fall risk outcome measures that relate to each of these 3 levels or domains within the ICF. Body structure function, so what we're going to choose from that unit of the ICF model is looking at tools that measure strength, biomechanical range of motions, limits of stability, and small components of body system function. We will take a look at activity-based outcome measures that will give us a fall risk rating or score or time. There is a long list of activity-based functional tools, excuse me, functional tools to use. So we will help you take a look at those and analyze them so you can choose the most appropriate ones for your population. And then taking a look on the participation side at how confident people are with their balance and how that relates to fall risk. So we're going to take this model and sort of go through the fall risk outcome measures by ICF domain. The first domain we're going to talk about is body structure and function. So what we're going to be measuring with the tools of this list are body systems problems. There are two pretty good tests out there to measure lower extremity strength in a functional way without doing a manual muscle test or dynamometry. We've got the 5-time sit-to-stand test. This is a very quick test. It requires a person to stand up and sit down completely 5 times from a standard-sized chair, and the person is timed doing this test. If they can't do the test within 15 seconds, they are considered at risk for falling. The multiple lunge test is another measure of lower extremity strength, and it requires the person to do 5 complete lunges that are at least 60% of their in distance of their own leg length. So it's determined by their leg length. And if they cannot perform all 5 lunges correctly, they are at increased risk for falling in the adult population, older adult population. Two other tests that are designed to measure the use of sensory systems for balance and postural control are the sensory organization test and the Romberg test. The sensory organization test requires a computerized system, the Neurocom Equitest or Smart Equitest. It's a 6-condition test that actually measures the use of vision, vestibular, and somatosensory information for standing balance under 6 different conditions. The composite equilibrium score is what gives us a measure of fall risk on this test. If the person is not using their systems well, they will score low overall on the averages on these tests. So scores below 38 out of 100 or scores that are more than 15 points below the person's normative range indicate increased risk for falls. These numbers are some of these numbers are presented on future slides when we talk about the psychometric properties of the tools, so you will hear them again. The Romberg test is a very simple, quick test. It takes about 5 minutes at the most, and it measures the ability to use somatosensory information in standing with the eyes closed, feet together, arms crossed on the chest. So it's quite an easy test to do. And then the functional reach test requires just a simple measurement stick. It takes less than 5 minutes to do and measures the ability to recover, to reach forward as far as possible and recovered from that forward limit. In the literature, if a person cannot reach greater than, if they only reach 18.5 centimeters or less than 7 1/4 inches, that increases the risk for falls in community-dwelling older adults. So you can tell that there's very simple tests in this category, but there is also a little bit longer test, the SOT, which requires some specialized equipment, but gives us a lot of good information on sensory organization. The modified clinical test of sensory interaction on balance, or the modified CATSIB, is not included in this discussion. It's used as a screening tool, but the psychometric properties of that tool are very poor. So it has not been included in this discussion. In the activity category on the ICF, there are multiple tools that are designed to measure different aspects of gait ability. Each of the tools in this list that you see have fall risk outcome measure cutoff scores or some sort of determinant of what indicates fall risk based on these tools. Each of these tools require the person to be an ambulator with or without equipment depending on the examination. Some of these tests simply look at gait speed and velocity, which is an important measure. Others look at characteristics of gait and the abnormalities that the person presents and variability in gait. Others ask the person to do higher level gait skills such as walking and turning, walking and stopping, up and down stairs, even walking backwards and with the eyes closed. So to go over these briefly, the dynamic gait index and the functional gait assessment are sort of test sisters. The FGA is based on the dynamic gait index, and it is a modification of that test. Both of these first two examination tools take about 20 minutes to perform. They require some simple equipment like a stopwatch, a box, a few cones for the DGI, stairs, things like that. And they each have, let's see, the dynamic gait index is a 8-item test, whereas the FGA is a 10-item test. And they're designed to measure the person's ability to stay stable while they're performing these high-level gait activities that include obstacle avoidance, walking up and over objects, walking up and down stairs, etc. So the DGI, Dynamic Gait Index, fall risk cutoff for that is less than 19 out of 24 points. And for the FGA, the cutoff is 22 out of the total of 30 points. So less than 22 out of 30 indicates fall risk. The Modified Gait Assessment Rating Scale, or modified GARS, this doesn't require equipment. It's pretty quick to perform. It's an observational gait test. It takes about 10 minutes and rates the severity of gait deviations on 7 different items. People who perform this test get points added if they have deviations. So scores over 9 out of 28 indicate fall risk. The GaitRight system is a computerized mat that measures characteristics of gait, including speed, cadence, step length, stride length, swing time, stance time. And when we get to the tables, when we look at the reliability and validity of some of these tests, the GaitRight characteristics are listed on there and the cutoffs for those. Gait speed is widely measured, and it's also an indicator of fall risk. There's multiple ways of measuring gait speed. The 10-meter walk is one of the most popular methods, and then there is also a 4-meter walk, a 2-meter walk test, 20-foot walk test, 25-foot walk test. Very simple to perform, only requires a stopwatch and a known distance, and you can measure speed over that distance. There are multiple different cutoffs for this, but primarily the range between 0.7 to 1.0 meters per second and slower indicates fall risk in older adults. Okay, then a lot of our tests, and if you take a look at the next list here of activity-based outcome measures, have multiple components to them, and they measure various constructs of balance and postural control, gait, transfers, turning, stance stability, even ADLs. So, and they're at all different levels. Some start very, very low, so the lowest skill that might be tested is simply sitting in a chair, whereas others go all the way up to measuring leaping, bounding, and reactive stepping, and things that are much higher level for adults to perform, especially older adults. The timed up and go test is a very, very popular test. It's widely used to measure fall risk in adult populations, especially older adults. It only requires an armchair, a stopwatch, and a 3-meter pathway, and it can be done within 5 minutes. Even multiple trials can be done fairly quickly. It really, all you're asking the person to do is stand up from a chair, walk 3 meters, turn around, come back, and sit down within a certain amount of time. And scores over 13.5 seconds indicate fall risk in community dwelling older adults. So because of it's a highly utilized tool because it's very, very fast, very quick, and very reliable. The Berg Balance Scale requires a stopwatch, a stool, a measuring stick, and some small items to pick up from the floor, for instance. It has 14 items and takes approximately 20 minutes to complete. It starts as simple as having the patient sit in a chair and then transfer, and then measures various aspects of standing stability, turning, reaching, unilateral and tandem stance, picking up objects from the floor, and skills such as that. Scores less than 45 out of 56 indicate fall risk in older adults. However, recent studies have come out by Myers and Berg being the the creator of the tool, that indicate that it's best used as a continuous scale and not a dichotomous scale with a cutoff. So she prefers that we actually use this tool to indicate where lower scores on the test indicate increased fall risk, but that a single cutoff score should not be given. Most people in the community, in the clinics, are still using the cutoff score of 45 out of 56. The TNEDI Performance-Oriented Mobility Assessment, or POMA, also a very widely used tool, one of our older tools in these categories. It's been around since the mid-'80s. It is a 16-item test. It has two subscales, one for balance and one for gait, that both are validated separately for fall risk. It takes about 10 to 20 minutes to perform and requires minimum equipment, just a stopwatch, a chair, and a walking distance. It measures sitting ability as well, and then transfers, standing, reactive standing, turning, and then the gait portion looks at gait deviations during walking and variability. Scores of less than 19 out of 28 indicate high fall risk, and scores between 19 to 24 indicate moderate fall risk. The Balance Evaluation Systems Test, or what's called the BEST test, is in its third version right now. Faye Horak created this test back in 2009 or so, and it was developed to be a comprehensive test of balance and mobility, and she intended to include activity restrictions that were related to balance across 6 different body systems and 6 different constructs. So it is a much more comprehensive examination tool, including things like getting up off the floor, as well as a sensory organization test. The CATSIV is embedded in that as well. It's a longer test. The original test takes approximately 30 minutes or more to perform, depending on the patient. There are 2 more current versions available, the Mini BEST test and the Brief BEST test, that both have are showing promise in fall risk. Lower scores on these tests indicate fall risk, but no cutoff scores are identified in the literature as yet. So we were looking forward to those. The Fullerton Advanced Balance Scale, or the FAB, is a 10-item test. It is designed for more active older adults that are living in the community. It takes approximately 20 minutes to perform. It requires basic tools such as a stopwatch, an AirX balance pad, a bench. This one requires a metronome because we're going to be challenging the person to walk at a certain pace, and measuring stick and things to pick up off the floor. It has a designated cutoff score of 25 out of 40 for fall risk in the older adult population, and really is designed for higher level balance clients that require a little bit more challenge. This one tends to have not have a ceiling effect, where the TNEDI examination tool directly above it has a ceiling effect for a lot of older adults. The physical performance test and the short performance physical battery. These tests I don't see used quite as much in the clinic. They are nice tests to be able to put on your choice of tests in your battery that you choose, however. The physical performance test, or the PPT, has 9 items, takes about 20 minutes, and it has a few different types of balance constructs that it measures. It is looking at a variety of ADL functions, such as eating and dressing. It looks at writing, so upper extremity dexterity, walking, stairs, lifting, picking things up off the floor. So it has a few different items that might be appropriate for your populations of interest. The lower scores on that test indicate increased fall risk. The short performance physical battery is only 3 items. This one has the 5-time sit-to-stand test embedded in it, which is a timed stand test. The second item on this is a variety of decreased base of support standing tests, such as standing with feet together and standing in tandem. And it also measures walking speed. So we've got several different things here related to stance stability, lower extremity strength, and gait ability. Lower scores on this test also indicate increased fall risk. Let's see where we are here. There are a couple others that don't fit into the first 2 categories of gait and multi-component tests. One of them is the 4-square step test. The 4-square step test is gaining a lot of momentum these days. It only requires 4 canes set up to make 4 squares, requires the person to systematically step and put both feet in all 4 squares in one direction and then repeat the same thing in the opposite direction, and the person is timed. Scores of greater than 15 seconds are indicative of fall risk. So it only requires a stopwatch and canes. However, there is a fairly large cognitive component to this. If the person does not pay attention, they may take multiple attempts to do this or not be able to complete the test. The single limb stance test, or one-leg stand test, also called the unilateral stance test, this is a really quick and easy test. It takes less than 5 minutes, definitely, to perform several trials of this. In the literature, it's been shown that people who cannot stand on one leg for 5 seconds, if they're at less than 5 seconds, are at risk for falls for community-dwelling older adults, and this is with eyes open. So, and this is one of those tests where, as people age, they're not expected to do as well on this test. However, that 5-second cutoff is a really nice, easy screening tool to use. In the participation category of the ICF, we know fear of falling is a factor related to falls and fall risk in older adults. People that are afraid of falling tend to limit their activity. They're not as confident doing all their daily activity skills, and they tend to get a bit weaker. So we have one participation measure, which is a balanced confidence questionnaire that actually has a fall risk cutoff range and has been proven to be fairly sensitive in measuring fall risk and in being used as an outcome measure for intervention programs and research studies. It's a 16-item questionnaire that asks the person to rate their confidence in performing various activities. Some of these activities are things like climbing up on a step stool or reaching up into a shelf, walking across a parking lot at night, those sorts of activities. And it goes all the way up to more difficult items such as walking on icy sidewalks or carrying packages on an escalator. So people rate themselves, and it's been shown that if their confidence is less than 67% out of 100, 100 being completely confident, scores of less than 67% indicate fall risk. And this is a pretty quick tool to use, so it's a really nice complement to round out the ICF model if you're picking at least one tool from each of those categories. I want to take a brief look now at psychometric properties of these tools. I'm going to show a few slides that define the terms on this slide. In the rehab professions and in research, we need to choose tools that are reliable and valid. We need tools that really show us that we're testing what we want to test. We want things that are responsive to change. And there are a few tools that we have some idea of whether or not they have some clinical importance to our patients if we see that the scores change. We are most concerned with reliability, whether this is a consistent tool over raters, between test times, and things like that. So we'll take a look at those numbers in a moment. As I said before, all of the tests we're looking at today have been shown to be valid tests of some balance construct for community-dwelling older adults. Sensitivity and specificity of the tool is important. We want the sensitivity is the probability that someone will, with the problem, so if they're at risk for falls, that they will actually test positive on that tool. And the specificity is the probability that someone that doesn't have the problem, who is, for instance, not at risk for falls, will test negative. And that's what we really want. We want these numbers to be as high as possible. The responsiveness of the tool is important because we are concerned with the ability of a test to demonstrate change. A lot of us are in rehab professions. We are looking at creating interventions that will help our person decrease fall risk. So we want that to be sensitive to change. We also want to know something about the minimal detectable change and the minimal clinically important difference. These values are not available for many of our outcome measures. We are concerned with the smallest amount of change that passes a threshold of error and reflects a true difference. So how many points improvement do we actually need to show that passes the point of just experiment or error, for instance, or equipment error. And the clinically important difference is the smallest difference the clinician or patient should perceive as beneficial. We wish we had more MCIDs for our tools, but that's a hard thing, sort of difficult to measure and to find in some of our measurement tools. So I have a few tables for you here. These are mostly for reference. The author and date of the article are given to you next to the tool. On the first column, the tool author date and test. The fall risk score and cutoffs that we spoke about before are listed for you here. The reliability, and if we look at these numbers, the closer the number is to 1, so if something is in a 0.8 or a 0.9, that's good to excellent, and then the 5s and 6s are moderate range. And then sensitivity and specificity, minimal clinically important difference, positive predictive values, those sorts of things are listed for you in the other column. We want those numbers to be as high as possible as well. So we're taking a look at the construct of the tool and how it's been tested in community-dwelling older adults. Now, a lot of these tools have been tested in multiple populations and widely used, so these are only the values for older adults. So we can see that the 5-time sit-to-stand is a highly reliable test. The multiple lunge test is showing some promise. The SOT varies widely depending on the study you read and depending on which condition is being measured, but it is fairly sensitive and specific with a clinically important difference of 8 points out of 100. So we know that if we make an 8-point gain on that test, that we actually have made some good clinical change in our patient. And then the Romberg test, very highly reliable, very quick test to do for our clients. On the activity-based outcome measures for older adults, the dynamic gait index and functional gait index, you can see that cutoff scores are listed there for you. The inter-rater and intra-rater reliability scores are quite high, and they are able to identify fallers with fairly good, moderate to good specificity and sensitivity there. Looking at the other gait characteristics on the GARs, again, there are 2 versions of this test. The one that is the modified or shorter version has a cutoff score of 9 out of 21, whereas the original GARs takes a little bit longer and has a cutoff of 18 or more points being rated for fall risk. The Tinetti inter-rater and test-retest reliability scores actually quite high on that. Although in the community I hear people complain about this test that it's fairly difficult to interpret some of the items the way they're written. So it needs to be a little bit practiced. It has to be practiced in your clinic to be used reliably. There are values for the balance and gait subscales as well. So if someone scores less than 11 out of 16 on the balance subscale or 9 out of 12 on the gait subscale, they are also considered to be at risk for falls. Again, this test tends to have a ceiling effect for more active older adults. They'll score 28 out of 28 quite easily. For gait speed, any of these timed tests, and most of the ones on that this slide right here are all time tests. We know that time is a very reliable measurement tool to use. So cutoffs, depending on what you read in the literature for gait speed, for the 10-meter walk test specifically, are anywhere between 0.7 to 1.0 meters per second, or somewhere around 0.8 meters per second. The normative range for the older population is already at about 1.15 to 1.35 meters per second. Men and women differ on that, and there are multiple different gait speed measurements for all different populations and environments. So you need to go to the literature to find specifics related to your population you are going to be measuring. And then a very small clinical difference is important on that test. For the 20-foot walk test, that has also been studied nicely, and less than 1.8 feet per second has been shown to be a fall risk measure. The timed up and go I mentioned before is a very highly used, very widely used test, and scores of greater than 13.5 seconds have been shown to indicate fall risk. Very sensitive and specific, and nice inter-rater and intra-rater reliability. So that gets a star for all qualities for time and psychometrics. The GateRight system, which is a computerized force platform, it's a mat with markers. It actually predicts fall risk. Here are in different measures of gait characteristics, such as the stride length, cadence, swing phase, double limb support, stride length, variability, and swing time. If these vary by about 10% or 10 steps per minute or 10 centimeters, they indicate increased risk for falls. So that's also a very objective way to quantify walking characteristics and rate fall risk. The Berg Balance Scale has been considered a gold standard in fall risk and balance tools. A very good reliability and moderate sensitivity and good specificity. For older adults, there are various cutoff scores for this. There's another, the article by Riddle, 1999, actually rates the fall risk cutoff at 50 out of 56, saying that it's a little bit more sensitive of a tool. And then there are other cutoffs related to different types of mobility status. The best test, no fall risk cutoff score has been established. Inter-rater reliability is very high. And it's showing really, really good utility in the clinic. I'm hoping this test gets studied a lot more so we can use it more in the clinic. The physical performance test, lower scores and even low scores designed with low grip strength, actually paired with low grip strength, are shown to be very good indicators of fall risk, with a minimal clinically important difference of 2.4 points on this test. So we do have some idea of how much change is really clinically significant. The last few activity-based outcome measures are single limb stance, which is, again, quick and easy. It's a time test, so the psychometrics are quite high. The 4-square step test of greater than 15 seconds, meaning fall risk, very, very good high inter-rater reliability and test-retest reliability for this examination tool. Again, it's a timed tool, very sensitive and very specific. As far as measurements, psychometrics scores very high. And then functional reach test, again, a real simple test. About 6 to 7 inches forward reach is considered to be indicative of risk for falls. In older adult populations, there are multiple older adult populations that have been studied for this test. It's you measure it with a yardstick or a centimeter ruler, and it's very reliable as well. The only test that's really available for us in the participation outcome measures is the ABC. With a cutoff of 67%, it is able to identify future fallers at a quite high percent with really good test-retest reliability. So we are giving that one a star as well. At the bottom of the screen here, you will see a website address for rehabmeasures.org. If you're not familiar with this website, please go there. You can type in almost any of these outcome measure tools and find all of the properties of the tool, and usually a link to the form itself, so you can easily see that. So the best tools, depending on impairment, the 5-time sit-to-stand test for leg strength. This is related to reliability and the quickness and utility of the test. The activity-based measures being the tug for transfers, gait speed, and turning, and the 10-meter walk test for gait speed, and the ABC for balance confidence. So if you look to see what's missing there, there's a few things that are related to balance and falls, such as sensory organization. So we need a test of sensory organization so we don't miss that component of fall risk. If you're looking for a more comprehensive tool that actually has all those constructs built into it, the best test is probably going to be a hugely used tool. It's really looking like it's going to be fabulous as it continues to increase its popularity and being used. And then the Berg Balance Scale and Tinetti Performance-Oriented Mobility Assessment, both widely used. Berg Balance Scale does not have a gait component, so usually, oftentimes that one is paired up with the Timed Up and Go test to capture the gait ability, or with the gait component of the Tinetti, which will measure gait characteristics. And then again, the ABC for balance confidence. We need to consider time, equipment, the knowledge of the tools, and the minimum level of client participation that's required. So even if your client is non-ambulatory, they will not be appropriate for some of the tests that require walking. If the client cannot get out of a chair without assistance, they are not appropriate for the 5-time sit-to-stand test because that's an all or none test. If the person if they are expected to be able to do higher level skills but can only sit and barely transfer now, start with some of the other harder tools such as the Berg, the multi-component tools, Berg, Tinetti, etc., and get a baseline measure for planning your treatment intervention in the future. So many of these tools, they're valid and reliable, they're quick to use, and they've been well proven for use in older populations. Once the tool is complete, the clinician, researcher, therapist can identify problem areas based on the individual items of each test. From those items, the appropriate balance problem can be identified, and the skills to train that can be used and trained efficiently. So it's nice to have these objective measures of balance and mobility to be able to figure out what the problem is and plan the treatment. And then thirdly, to use the outcome measurement score to document progress. As the intervention is progressing, you want to know whether it is effective in reducing fall risk. So these tools give us an idea of that. I listed a few resources at the bottom of this page. These are related to fall prevention. The Center for Disease Control here in the USA has a fall prevention and safety web page that's comprehensive. Mayo Clinic has a fall prevention page, and then the stopfalls.org, which is the Fall Prevention Center of Excellence. All very, very good resources for you in your clinical or research venues. So that concludes the presentation. I want to thank all of you for your attendance.
Dr. Roller, thank you so much for your time today in presenting this very detailed outline in regards to our topic, fall risk reduction in older adults. Thank you so much for attending our e-seminar. This will conclude today's presentation.